Hi, good evening, everyone. So I presume we have about 64 participants now. I think about 320 has been registered in this. Sorry, 97 now. Wow, that's very good turnout, considering at this time of day, everyone just leaving from work and driving back home. So basically, my name is Dr. Nick Ritza Kosai. I'm one of the UpperGI surgeon. So basically, I am actually privileged to introduce everyone here. And I'm actually very proud to present the first series of our UpperGI virtual grand round, okay? And we have 9 series which will commence every 2 weeks on interesting UpperGI cases, where every one of you have the opportunity to ask and hopefully learn from these interesting cases. Now, just briefly talking about this UpperGI Grand Round series, the idea came around as now we in Malaysia has a single pathway for UpperGI subspecialty training. Me as part of the committee, including several others which have actually joined in today, has come up with an idea that our subspecialty trainee should be able to engage more, not only nationally, but also internationally. In particular, trying to disseminate and deliver as much knowledge, in particular, specifically in UpperGI cases. So without further ado, I'm going to introduce our first speaker of the first series of this UpperGI surgery grand rounds. We have here is Dr. Sekkapan. Dr. Sekkapan is an UpperGI subspecialty trainee year 1. He has been a general surgeon, I think more than 3 or 4 years now. We have the opportunity in my hospital as one of the training center to train Mr. Sekkapan, and I'm actually very, very privileged to introduce Mr. Sekkapan, who has a very, very excellent UpperGI surgical acumen, okay? And I'm also very pleased to introduce Mr. Sekkapan, who is actually going to talk on a very interesting topic. And the topic is 3-field lymphadenectomy in esophageal squamous cell carcinoma. Question is it feasible in Malaysian setting? Okay, so without further ado, I let Mr. Sekkapan to start his talk.
Okay. Thank you, Prof. Nick, for the kind introduction. Okay, definitely I'm privileged to work with you in HUKM to be trained by Prof. Nick. And good evening to all the consultants and those who are attending this webinar. So I'll be talking about this 3-field lymphadenectomy in esophageal squamous cell carcinoma, which is, we had a recent experience in our center. So the topic would be, is it feasible in Malaysian setting? So these are my outline. So basically, I'll be talking about esophageal cancer per se. What are the numbers in the world, and what is the burden of esophageal cancer in Malaysia, and our recent experience about 3-field lymphadenectomy with some literature review as well. So basically, esophageal cancer has affected more than about 572,000 people in 2018. This is worldwide, and is responsible for about 500,000 deaths as well, meaning that it's about 5.3% of all deaths globally. So in that sense, esophageal cancer, it's associated with high mortality and poor prognosis, which is well known to everyone. On top of that, the incidence of esophageal squamous cell carcinoma has been reported as high as 100 cases per 100,000 population in Asian esophageal cancer belt, extending from Northeast China to the Middle East. So what about Malaysian esophageal cancer burden? So basically, based on the report, Malaysian National Cancer Registry report, over 4 years, 2012 to 14. So incidence is about 1.4 over 100,000 in male and 0.5 over 100,000 in female, total about 788 cases. Probably the numbers are quite low because of reporting. This is over 4 years. But otherwise, based on the ethnicity, of course, Indians, whether it's male or female, has a higher incidence of esophageal cancer, basically about 2.4 in 100,000, and for male and female is 2.1 over 100,000, whereas Malay and Chinese is about 1.1, 1.6. So this is another one about Global Cancer Observatory 2020. So where is esophageal cancer? How many cases are reported per year? So I'll zoom in. You can see esophageal cancer is about 398 cases reported per year, which is ranked at 21st when it comes to all type of cancer, which has been reported all as well. And what are the stages that they come with? Most of them actually they come with stage 4, 75% is quite high, whereas stage 1 is only 5.7%. And then when you talk about 3-field lymphadenectomy in esophageal SCC, so this has been practiced since 1980, especially in Japan. And what it means, 3-field lymphadenectomy, it includes dissection of lymph node, includes neck, mediastinal, and abdominal lymph node. Otherwise, despite recent advances in pre-op staging, you have CT scan, you have PET scan, ultrasound, and all, pathological finding after 3-field lymphadenectomy indicate about 75% of cervical metastases are not detected in pre-operative staging. And when it comes to Malaysia, so there are very little or no data has been published regarding the 3-field lymphadenectomy. It's just case-by-case basis. So it's just diaphragmatic representation on when you talk about neck dissection. When it comes to standard lymph node, including the abdomen and thorax, whereas when you 3-field lymphadenectomy, abdomen, thorax, and neck dissection as well, cervical lymph node dissection. So now we'll go into some literature review, some interesting papers with regards to this 3-field lymphadenectomy. So Leroux et al. Published in Annals of Surgery. So this is about 3-field lymphadenectomy for carcinoma esophagus. So what it says is overall 5-year survival or disease-free survival after R0 resection is about 41.9 and 46.3. So 5 years, which indicates a real survival benefit. In that case, of a 5-year survival of 27.2 patients with positive cervical lymph node of mid-third carcinoma of the esophagus. So it's actually a regional lymph node instead of saying it's a metastasis. Otherwise, this paper clearly shows this patient seems to benefit from this 3-field lymphadenectomy. Next is Yi et al. Again, this is a meta-analysis of the 3-field lymphadenectomy versus 2-field, including inclusion about 13 publications, and they've analyzed the outcome. Of course, looking at the 3-field group and 2-field group, the hazard ratio, of course, benefits clearly 3-field lymphadenectomy. So the 5-year survival is 0.64, meaning it has provided a better 5-year survival outcome. Next would be from Yajima et al. Also about neck dissection for thoracic esophageal squamous cell carcinoma. So when you talk about prevalence, the prevalence of positive cervical lymph node associated with tumors in the upper part of the thoracic esophagus. So it's significantly higher compared to the tumors derived from lower esophagus. So upper esophagus about 48%, mid is 28, and lower is 13. So when you talk about 5-year survival benefit in this study, is about 34 to 52%, with surgical mortality about 1.2 to 5%. But overall, T1, T2 tumors, of course, the survival benefit is about 57 to 88. T3, T4 tumors about 25 to 37. So although lymph node metastasis into the cervical field are classified as distant mets, but about 13 to 32% of patients survive more than 5 years after the clearance of the lymph node, which is similar values were obtained in a Western study as well. So here I'm going to share our recent HUKM experience. Okay, our patient who Mr. LTS is a 67-year-old Chinese male whom presented with dysphagia since March 2020 associated with loss of weight and appetite. But he has been visiting private hospital for his dysphagia, and only in July that he actually got it investigated because of the worsening dysphagia. OGDS, which was done at a private hospital, shows that a pedunculated mass 35 cm from the incisor, subsequently referred to us in HUKM. So HUKM, so we followed the investigation. So our OGDS also showed it's a pedunculated mass 35 cm from the incisor with contact bleeding and multiple Forest 3 ulcer at the body and antrum. Otherwise, CT staging shows as a heterogeneous enhancing distal esophageal mass causing significant obstruction. The issue here was a few consolidative lesion with foci of calcification noted at the apical segment of bilateral lung lobe. Need to rule out metastasis, or there was some suspicion about tuberculosis. But when you look at him clinically, of course, his malnourished, his BMI is only 16.5, but his ECOG status is good. And he was only able to tolerate liquids at that point. So this is our OGDS picture showing is a pedunculated mass at 35 cm from incisor with luminal narrowing. And this is a CT scan image showing it's an intraluminal mass as well, causing a significant narrowing of the lumen. So this is the one that few consolidative lesion on the apex of the bilateral lung with consolidation, calcification as well. So at this point, our HPE initially when we have taken came back as sarcomatous changes. It was pointing more towards sarcoma. So at this point, we actually repeated a scope, and since it's a pedunculated mass, we did a snare polypectomy. And at this point, the repeat HPE, that's when it's confirmed as spindle cell squamous cell carcinoma. So we proceeded with MDT, involving the oncologist, respiratory physician, radiologist. So what was suggested, what was discussed at that point is the tumor is resectable, patient is fit, nutrition can be built up, and we need to rule out either it's a tuberculosis, the lung lesion, or it's a metastasis. So we proceeded with lung biopsy. And that lung biopsy actually came back as chronic granulomatous inflammation. But this patient had a rapid PCR negative. So after a further discussion, so the respiratory physician decided to treat as smear negative PTB. So what's next? At that point, the respiratory physician started on anti-TB treatment. He was on Accurate. And we delayed the surgery for the patient to complete at least 2 months of intensive phase. Otherwise, we would have proceeded with the resection since it's a resectable tumor. So while waiting for the patient to complete this 2 months of anti-TB treatment, the patient was referred to oncologist and was started on cross regime, which patient actually completed. And repeat CT, TAP showed a complete disappearance of the esophageal mass, but the long nodule persists. So a little bit on this anti-TB treatment, there's no actually published paper on the duration of anti-TB treatment before proceeding with surgery. When can we say this is safe now for the TB patient to go for surgery? But just go by clinical practice, whereby we need to complete at least the intensive phase of 2 months anti-TB treatment. Repeat AFB must show smear negative. It definitely reduces the risk of TB spread among the operating personnel, and also reduces the complication such as anastomotic leak and fistulas. So for this patient, after the neoadjuvant therapy, we actually waited about 6 weeks before proceeding to surgery. Okay, this is one of the paper which I came across, which advocate is about 4 to 6 weeks of waiting period before proceeding for surgery, which gives actually a very good outcome in terms of morbidity and mortality. So when it comes to intra-op, so the real day of surgery, so we proceeded with total esophagectomy. These were done in 3 stages. Stage 1 was a thoracoscopic mobilization. So you can see this patient is in swimmer's position. So we have done a complete thoracoscopic mobilization. This is our port placement. We use 2 12 mm and 1 5 mm port. Okay, at this point, can we watch the video? All right. Can we play the video, Rocky? Okay. So what you can see is our dissection. It's actually a very clear plane can be seen. It's almost bloodless. Okay, we use a hook for dissection, which gives it is very precise for the dissection as well. Okay, so this is here we are dissecting on subcranial lymph node. This is above the pericardium. You can easily tease the tissue, dissect, and it's almost bloodless. This is actually a very nice dissection, which Prof has performed. And this is after we completed our dissection, the entire esophagus has been mobilized. So now we are going through the anatomy. So this is aorta, we have both crust, right and left crust. This is a pericardium. So you have right and left superior and inferior pulmonary veins with a pulmonary trunk. And later on, we'll come to a very bulky subcarinal lymph nodes, which was removed completely in this case. Yeah, very bulky subcarinal lymph nodes. And of course, this is the bronchus. You have a left and right main bronchus. So this was done beautifully, and it was a very fast dissection as well. Okay. So now we move on. So what happens next after the thoracoscopic mobilization? So this is our resected specimen. This is the whole specimen. And you can see once this is a cut open segment, previous tumor site just shows some scarring. There is no obvious tumor mass seen. Stage 2 was the preparation of the conduit. It's an abdominal approach. So whereby we have made an upper midline incision. We have made a separate cervical incision, neck incision, bring down the specimen, and to prepare the conduit. This is our prepared conduit on the stomach. This is the resected specimen. But at this point, our ENT team came in. So they did the neck dissection simultaneously. Okay, this is a pre-op marking. So this is how it looks like intra-op. And once this is done, so during the abdominal approach, the ENT team proceeded with the neck dissection as well. And last was the neck anastomosis between the esophagus, remaining esophagus, and the neoconduit. So this post-operative period, patient has actually recovered very well, activated at day 2, started on feeding jejunostomy. Only thing is at day 3, he developed neck cellulitis. At that point, we were worried whether it was an anastomotic leak. We did a fluoroscopy, shows there's no leak. It was a smooth contrast flow. So we just treated with antibiotics, continued feeding via feeding jejunostomy, and we discharged him at day 8 post-op. So this was the HPE of this particular patient. All right, so both the esophageal and stomach resection margin are free from malignancy. And you can see all the levels of cervical lymphadenectomy, which was done. Total bi-level lymph nodes, so far, I mean, none of it was positive. So in the end, the TNM staging, it was a T1 tumor, but this is, of course, post-neoadjuvant. So when it comes to three-field lymphadenectomy, there was some papers reporting some pitfalls about this three-field lymphadenectomy, like Yasoda et al. Compared these patients with three-field to two-field lymphadenectomy and reported a recurrent laryngeal nerve was higher in patients who underwent three-field lymphadenectomy. So at this point, we feel probably the recurrent laryngeal nerve injury commonly reported during the thoracoscopic mobilization rather than neck dissection. And then Nakamura et al. Investigated the gastrointestinal dysfunction between these two groups of patients. And there was some insufficiency in the gastrointestinal tract reported in the three-field lymphadenectomy. Otherwise, Ye et al. Reported higher anastomotic leak in three-field lymphadenectomy, but vocal cord palsy is insignificant when you compare the rate. So by conclusion, so burden of esophageal carcinoma is increasing with squamous cell carcinoma, and then three-field lymphadenectomy has shown a better survival rate with acceptable morbidities. So mortality and morbidity are comparable between these two fields. Hence, we propose tertiary centers with UpperGI services with good support from the head and neck team to perform these complex surgeries, which proven to improve patients' survival benefit. And we always talk about teamwork. Yes, always teamwork is the best outcome. This is our surgical team led by Prof. And this is our head and neck team led by their consultant ENT surgeon. All right, so acknowledgement to Dr. Yong. He was a surgeon who led the neck dissection. These are my references. And thank you from our SCC team.
I'm sorry, it was muted just now, sorry. So I would like to thank Mr. Sekkapan for a very nice, succinct presentation. So we are now open for a Q&A. So basically we have two forms of Q&A. One is you can do a Q&A through the Q&A box. And then there's another one is where you need to scan your QR code because there will be a survey which we just need you to scan the QR code and answer the questionnaire in the survey. Sorry, I'm just reading the instruction from another Zoom to instruct me for the next segment of our session. So first of all, of course, we would like to thank our sponsor for tonight's webinar. We have a 9 series of webinars and sponsored by different industries. And for tonight, it is Johnson & Johnson's turn. I think what we're going to do is we're going to play Johnson & Johnson's video presentation. In the meantime, please ask any question. You can go through the Q&A box, and also don't forget to QR code our survey. Okay, I will unmute myself and let the video by JMJ begin. Okay, so there are 10 questions posted already in the Q&A. Let's start with the first question by Eng Chong Beng. Any difference between type of cancer, adenocarcinoma and squamous cell carcinoma, and a location of tumors on percentage rate of cervical lymph nodes metastases? Okay, so Sekkapan.
So when it comes to esophageal squamous cell carcinoma, of course, the location matters. The mid-esophageal tumor has higher prevalence of the cervical lymph node compared to the lower third esophagus. But then when you compare squamous cell carcinoma and adeno-CA, whether there's a difference, so far there is no difference between this squamous cell carcinoma and adeno-CA with the prevalence of cervical lymph nodes involvement.
Okay. The next question is, would intraoperative nerve monitoring be useful? Do you routinely do it?
Okay, definitely intraoperative monitoring is useful, with some papers reporting incidence of Wokokoc recurrent laryngeal nerve injury. So that will definitely benefit the patient. But for now, we are not doing it routinely.
Okay, so the next question is, for 3-field lymphadenectomy, do you perform pre-operative indirect laryngoscopy for vocal cord function?
Yes, in this case, yes, we do. Again, it goes back to the incidence of the recurrent laryngeal nerve injury. So because you are doing extensive neck dissection, it's always advisable to get an indirect laryngoscope done pre-operative.
Okay. Okay, so then the next question is, when we use feeding methods for the patient, feeding jejunostomy versus feeding through the Ryle's tube, any preference for the esophagectomy?
Okay, so for esophagectomy, particularly in this case, we did a feeding jejunostomy, which we feel feeding jejunostomy is easier. We can resume feeding early in a post-operative period. Of course, it's definitely comfortable for the patient instead of rice tube going through their nose. And in case there's any complication happens, let's say an anastomotic leak, which we need to address, we might not be able to start feeding early. So feeding jejunostomy definitely helps a lot.
Obviously, occasionally there are always risk of leaks from the jejunostomy,
yes,
and which can actually increase the mobility of the patient, of course, which I think we have experienced one recently, where the feeding jejunostomy broke up over the purse string of the jejunum and caused, fortunately, localized peritonitis. So we had to go back in and resect the area and do a primary anastomosis. But by then the gastrographin of the anastomosis showed no leak. So fortunately, you don't need the feeding jejunostomy anymore.
Yeah.
Right. So the next question is, when would you do PET CT scan for staging? Do you think PET scan is helpful to decide between 2-field dissection and 3-field dissection?
Okay, PET scan now we do it routinely for this esophageal carcinoma to look for any distant metastasis. So in this case, when talking about 2-field and 3-field lymphadenectomy, there are papers published saying about 75% actually not detected preoperative. Even we have done a CT scan. Nevertheless, it is still, we do it routinely. It has a role. It can pick up cervical lymph nodes. It's about 25% still can pick up if there are significant lymphadenopathy in the cervical region.
So it's helpful?
It is helpful, yes.
Yeah, but I mean, do you routinely do PET scan on any patient as part of staging for patient with esophageal cancer?
Yes, we do.
Okay. The next question is, what type of tube used for feeding jejunostomy? In this case.
Okay, this one was a Malaysia catheter was used as a feeding tube, feeding jejunostomy tube.
Yeah, I mean, sometimes we use RAS tube as well. But with RAS tube, we normally do a submucosal tunnel. Whereas the Malaysia, we do 2 purse strings and tighten it up and fix it to the anterior abdominal wall. A question from Kelvin Boone. What is your strategy in preventing recurrent laryngeal nerve injury during the dissection of recurrent laryngeal nerve nodes? Station 106 in both intrathoracic and neck approach.
Okay, so when it comes to intrathoracic dissection, of course, when you're going into the thoracic outlet, we need to visualize. Okay, we need to keep close to the dissection must be very close to the esophagus, and if you visualize a recurrent laryngeal nerve, which has to be, you have to dissect away from the recurrent laryngeal nerve as well. And during the neck dissection, of course, we have to keep to the usual approach in sense, the recurrent laryngeal nerve location, looking at a tracheoesophageal groove and preventing any, I mean, must have a very careful dissection when you're approaching the tracheoesophageal groove. And on top of that, of course, this intraoperative nerve monitoring helps a lot in prevention of these injuries.
So can you do a intrathoracic nerve monitoring?
Right?
Intrathoracic nerve monitoring.
Okay, that not that I'm aware of. So it's more towards the neck dissection, yeah.
Yeah, then the nerve monitoring will be mostly helpful. I mean, our endocrine colleagues who does difficult thyroid cases use that routinely. I think nerve monitoring from Johnson & Johnson, right? We have, yeah. Okay, the next question is there any optimal timing for the surgery after the cross regime, like the example of neoadjuvant rectal cancer? And number 2, do you have any advice on anticipated problem one might face to do a 3-field lymph node dissection if we didn't give neoadjuvant treatment?
Okay, when it comes to optimal timing, the paper that I discussed during the presentation, the timing is between about 4 to 6 weeks. Okay, this is optimal timing post neoadjuvant for us to proceed with surgery, which gives R0 resection a better outcome in terms of R0 resection and less complication in terms of anastomotic leak. But otherwise, anticipated problem in 3-field lymphadenectomy if we didn't give neoadjuvant treatment. So in this case, for our case particularly, is neoadjuvant was given because patient was confirmed to have tuberculosis, so he has to undergo TB treatment first before going for surgery. So we gave a neoadjuvant therapy. But otherwise, so when it comes to 3-field lymphadenectomy, if we don't give neoadjuvant therapy, so anticipation, of course, if it is a bulky tumor itself, the dissection is going to be difficult if it is locally advanced. And in neck lymphadenectomy, it actually does not make any difference whether you are giving a neoadjuvant or not in terms of the nodes clearance.
Yeah, I mean, we had a few cases in the past where we did 2-field lymphadenectomy, and then the problem the patient came back with regional recurrence in the neck, and by then these nodes were very matted and quite significant and bulky around the anastomosis area. So we had to unfortunately treat this patient palliatively rather than potentially curative. So I think obviously 3-field lymphadenectomy should be the way forward of talking about, especially SCC mid-thoracic tumors, because as you see from all the papers presented, these are considered as regional rather than metastatic. The next question is in the line of the previous question. So how do you decide the chemotherapy in patient with active TB infection? What does the Malaysian Thoracic Guideline recommends?
Okay, so when it comes to this TB treatment, they have to undergo TB treatment at least for this 2 months intensive phase, and then proceed with surgery like what we did for this particular patient.
The question was, when do you decide for chemotherapy in patient with active TB? When is it safe to start chemotherapy in patient with active TB?
Okay, this is at least because to prevent the flare-up of the tuberculosis, so what was suggested is at least 2 months.
So
at least
that
an
means,
intensive phase.
So you mean treat the TB for 2 months before you commence chemotherapy?
Yes.
Right. The next question is, do you routinely ligate of the thoracic duct, especially in performing 3-field lymphadenectomy?
No, it's not a routine to actually ligate the thoracic duct.
Yeah, only when you injure it, then we decide to ligate it. But normally, I don't routinely ligate thoracic duct. And the incidence in our series with thoracic chylothorax or thoracic duct leaks is quite low. Is supraclavicular lymph nodes considered distant metastases generally, or it depends on the tumor location, Mr. Sekkapan?
It's again based on the tumor location. So mid-esophageal SCC. So whereby the supraclavicular lymph node, it's considered as a regional lymph node instead of metastasis.
Yeah. And last question so far that we receive is, would you recommend to do routine to routinely perform upper contrast study post-esophagectomy?
Yes, for all these esophageal resection, total esophagectomy, of course, we do a routine gastrography at day 5 post-operative period. Again, we are looking at any form of anastomotic leak, probably a stricture. So actually, we can rule out early. So it's definitely recommended.
Okay, so that is questions so far that we have received. I don't think we have any more questions. Well done, Mr. Sekkapan, able to answer all these questions calmly. Yes. I think we have another 10 minutes. 10 minutes before we end this webinar. Feel free to ask any questions. Mr. Sekkapan.
Yes, Prof.
How what would your advice be? Now, of course, in HUKM, we are privileged to have a very good head and neck ENT team. And we are quite used to do a lot of pharyngolaryngectomies with gastric pull-ups or whatever conduit we use because of the presence of head and neck surgeon who did, in this case, a very beautiful, clean neck dissection. So how would you recommend in centers where they don't have a very good head and neck or no head and neck surgeon that could help do the neck dissection?
Okay, so when it comes to this, things like logistic issues, like we don't have a head and neck surgeon. Not every center has to perform this neck dissection. So in that sense, probably my suggestion would be, one, we need to collaborate with the head and neck unit, whichever hospital has the unit. We can collaborate with them, bring them over, and perform the surgery together in our center. Or the other choice would be is the surgeon himself to learn this neck dissection during, either from the head and neck surgeon, or we do an attachment for it to learn this neck dissection and to be able to perform independently.
Let's have a look if there's any more questions. Any more questions from the audience? Feel free to ask. As I said, this is we hope the present audience, I think it's nearly 300 plus who has registered for tonight's webinar, and I thank you all for joining us. Like I said, this is one of the 9th webinar organized by Malaysian UpperGI Society in conjunction with UpperGI subspecialty training. One of the main aims is to ensure that our trainees are well engaged in presentation, boost your confidence. Obviously these guys are eventually going to be an UpperGI surgeon and hopefully somebody in the country in the future. If you look through the topics for the next 8 other webinars, they are all very interesting all are very pertinent to not only general surgeon, but also those who are interested in upper GI surgery and those who are specialist upper GI surgeons. Also in Malaysia, the cases are very, very interesting. Cases are very interesting. So please join us for the next subsequent webinars. The topics are very, very interesting and very, very pertinent for our current daily clinical management. Any other questions? We have a few more minutes left. Don't miss the opportunity to ask questions. Mr. Sekkapan is happy. He's done a lot of research in this part. Yeah. So, okay. What is the opinion in using bipolar for dissection near the recurrent laryngeal nerve to reduce the chances of injury?
Okay, using any form of diathermy, energy device, of course, it has its lateral spread, and there's always increased risk of nerve injuries. So in this case, I think whatever it is, the plane of dissection, keeping away from the nerve towards the thoracic outlet, keep close to the esophagus for the thoracic mobilization, and neck dissection, of course, following the anatomy is crucial to prevent any injuries.
Okay. Another question: is there a role for double stenting? We're talking about palliative stenting here, especially in long segment esophageal tumors. These are non-operative palliative stenting.
Okay, so when it comes to stenting, palliation, okay. This is considered as palliative cases. Palliation will just stent. In a long segment, of course, this double stent, there is a role to relieve the obstruction, okay, since it's palliative case, so the patient can have a quality of life. But of course, when we talk about this double stenting, it comes with its own complication like stent migration, erosion, esophageal perforation. You have to keep in mind about all this complication before we embark on double stenting.
Okay. Is there any difference in survival between chemoradiation alone and surgical treatment with chemoradiation in squamous cell carcinoma?
Okay, definitely there is a survival benefit whoever has undergone chemoradiation with surgery, because there are papers who suggest, Western papers saying that after chemoradiation, especially in squamous cell carcinoma, whether we should do a esophagectomy. Of course, we recommend to do the esophagectomy because it has a submucosal spread of the squamous cell carcinoma. And a patient who has undergone chemoradiation, resection, definitely survival benefit is much better than those who have not gone for surgery.
So far, we don't have any more questions. I think we have 4 more minutes left. So before we wrap it up, any advice with regards to young, ambitious upper GI trainees, your colleagues who are planning to embark on esophagectomies, especially similar to our cases? What will your advice be to your colleagues?
Okay, first, of course, we need to undertake such complex surgery. We shouldn't say no, it is not feasible. It can be done. We have done it. So this is a proof. And good to have a mentor So in my case, I had Prof. Nick as a mentor to guide us through the surgery. And always we shall do it together. So in terms of my colleagues who are in training, I think we will work together. And we should go do attachment, learn from the experts on different skill sets. And of course, you need to establish a good rapport with ENT team, especially the head and neck unit. If we don't have most of our cases in KKM, we don't have a head and neck unit. Of course, we can talk to them, invite them over for a case. But definitely this can be done.
I agree with Mr. Sekkapan. I mean, for those ambitious surgeons out there in Malaysia who is interested in UpperGI, you know, we are now very privileged to have a single pathway. So the training is open for all surgeons in Malaysia. Obviously, you have to fulfill, you know, very specific criteria. There are application forms. The committee will review the application forms, and these candidates will be interviewed. And those who have fulfilled the important criteria will be eventually selected into the training system. And now, at the moment in Malaysia, for Malaysian surgeons who are watching, the training is for 3 years, 1 year in each training center. So the designated training centers so far in the country at the moment one is Institute Cancer Negara, Hospital Sultanah Aminah in Johor Bahru, Sarawak General Hospital, and Hospital Chancellor Tuanku Mukhris PPUKM. Okay, but soon I think we will incorporate Hospital Pulau Pinang, Penang General Hospital, and University Malaya Medical Center. Okay, we are proud to have a dedicated specialized UpperGI surgeons who has been accredited as trainers for each of these centers. Like Mr. Sekkapan is currently in his first year and is training under me in HCTM. And there are other trainees who has been allocated at a different training center, as I mentioned before. So with the current single pathway, it is open and fair for everybody who is interested in doing UpperGI subspecialty training, you know. So feel free and please, you know, the interest by general surgeons in joining UpperGI training has increased lately. So we are quite pleased with that. Okay, and of course we do need more UpperGI surgeons because you know, previously it has been the least subscribed subspecialty in this country, and I'm pretty sure with more specialist UpperGI surgeons, you know, I think the underreported UpperGI cancer would probably be more than what Mr. Sekkapan has, you know, shown us. You know, the numbers of esophageal cancer, I think from 2016 to now is only 750 something just now. Okay, so yeah. So I think it is 9 o'clock. So before we end this webinar, I'd like to thank again, you know, our tonight's main sponsor, Johnson & Johnson, for sponsoring this webinar, and thank all other industries who has sponsored these 9 series of webinars. And but most of all, I would like to thank the audience for being with us tonight, and we hope that you guys have learned something, and we hope that the same faces will come and join us in the next webinar, which I think will be in 2 weeks' time. Have a look at the schedule. We have the program schedule and specific dates, and I think yes, I think the organizer wants me to highlight tonight there is 223 participants. So we are very pleased with that. And thank you for joining us. This is actually a rare, having to have a very specific webinar on UpperGI is not that common as opposed to compared to colorectal or others. So we take stride to ensure that, not only we try and train and give our best to our UpperGI specialist training in Malaysia, but also those from abroad as well. So the next webinar will be on the 12th of March, same time, 8 p.m. The topic will be duodenal perforation, repair and salvage techniques. Okay. So it'll be another interesting topic. We chose all these interesting topics because I think we felt that it's pertinent to general surgeons. Okay. Of course, we, by giving you all these insights to how to do and manage these problems properly, hopefully we can try and reduce morbidity and mortality, because we are still seeing a lot of morbidities and mortality in especially cases with gastric, duodenal or peptic ulcers perforation. Yeah. Okay, so thank you very much. So we hope to see you guys again in our next webinar. Don't forget, 12th March, same time. Until then, good night, everyone.
Thank you, Prof. And thank you, everyone.